So firstly, thank you, Sayendri, for such a gracious and warm welcome for me and saying those encouraging words. It really means a lot. And so I've also been empaneled as a remote associate with the Center for Care. So it's really special for me presenting my research in front of all of you. So, as we already know that my presentation or my paper is titled as Intimate Transactions in Care Work, Precarity, Purpose, and Pleasure. So this is the way we are going to, move ahead. Just to give you a roadmap regarding the presentation, so that we all sit tight and go through it. Now, just to acquaint you with the background of the study and what made me actually go ahead with this particular paper. So, robust interventions in healthcare and control of higher incidence of infectious diseases has resulted in low mortality rate or compression morbidity through delaying disease onset, which has ultimately resulted in the rectangularization of survival curve and increase in lifespan. Technologization of medicine has enabled survival of human beings through the incorporation or installing of machine, including heart pacemakers, transistor hearing aids, and dialysis machines for kidneys. Such human beings are known as cyborgs or bionic bodies. This cyborgization further contributes to the lengthening of the lifespan. Now, in the Indian context, low competence of the public health systems, especially the PHCs, that is primary healthcare sector, it has failed to address the growing health issues of the emerging number of older people. At the same time, high out-of-pocket expenditure with increased incidence of geriatric disease burden and severity of sickness, and burgeoning of the for-profit private healthcare sector through commercialization, corporatization, and marketization are the determinants of seeking alternative extra-aging, relatively low-cost home-based services. This necessitates taking stock of the preparedness of preventive, curative, and rehabilitative healthcare services and advocate for campaigning and implementation to address urban aging. I also argue that the state or the policymakers' injunction to confine and limit healthcare services or taking care of older people within the home care and within the primary care networks also it has gradually led to the path of commercialization of intimacy and commodification of care, and it has largely profited the healthcare market in general. Now, before we move on to understanding who are ayahs, we also need to figure out that how within the Indian or the larger South Asian context, care as a landscape is imagined. Now, care within the Indian context has traditionally been family site based and within and continued or carried out by the through the family. So it also becomes a way of solidification of your intergenerational relationships, reciprocity, and it is associated as seva, duty, something that is incultured and indoctrinated through the primary socialization. And therefore, aberration from it or meandering from it also evokes negative sentiment among older people. They feel that they have failed to raise their children in the right way or in the appropriate manner. And this understanding is crucial to also navigate with or negotiate with the entry of the ayahs. Now, are the ayahs? Now, in contemporary post-colonial, so in the British period, the ayahs they were recruited as nursemaids or as handmaidens for the wives of the British colonial masters, and they also were employed to take care of the children. Now, this is very interesting, especially keeping in mind that in the present context, when we will try to understand what happened to the ayahs, this is going to facilitate our understanding regarding why ayahs are still, stigmatized. Now, during the British colonial period, as we have seen, the ayahs, they were not trained professionals, right? And what we also found in the present context is that they are continuously compared with the trained professional nurses. Now, these trained professional nurses, they embody a figure of professionalization, modernization, and in a way, uh, they represent a possibility. They represented a possibility for modern women to seek employment in a very dignified manner. However, with the overrepresentation or presence of lower caste women, so I would like to point out here that these ayahs, whom we are going to talk about, or who also constitute as the protagonist of my study, they are largely lower caste women, and their life world is very different from that of the trained professional nurses that we are going to talk about. And it was and what we can see is that this despite the efforts to destigmatize the stain associated with the nursing profession, the ayahs, they have continued to remain at the margins. Now, the taint on the nursing profession can be traced to the recesses of history wherein lower caste Christian convert or working class women were pulled in via medical missionary, military, or philanthropic organizations. The tasks and activities of nursing, marked by dealing with bodily fluids, blood, and cleaning and changing dirty clothing and bandages, made it the reserve of lower caste populace. Now, with formal employment rate, one can see that although educated female labor force has, they're part of the economy, but they are also ghettoized within the service sector. Unlike these ayahs who are part of the unorganized labor market or the informal market. This, along with the feminization of the occupation, results in their penalty, devaluation, inequity, and precarity. Now, with ayah care emerging as an alternative to the traditional practice of family based care arrangement, this particular presentation is interested to understand what is the nature of intimate labor an ayah provides to an aging body. That is quite important. So we are not here interested in ayahs who take care of children, although through the narratives, ayahs have continuously tried to draw comparison and aberrations between taking care of a child and taking care of an older person, but we are largely here interested to discuss about ayahs taking care of aging bodies, the immediate and long term effects of taking care of being part of such an intimate care labor, the stakes for the ayahs and their delivering strategies of managing repugnance and stigma, and in this and the ways they and the different microaggressions or strategies through which they show their resilience. As you can see in this slide, so there are different ways an ayah enters into the profession. So within the ayah subculture, they use terms like direct service and indirect service. So by direct service, they mean when a placement agency or an ayah care agency is not involved. In that case, so they have these three modes of entry. The first being transition from a paid domestic help to that of an ayah. So this is where I would also like to underscore the aspect of trust, the aspect of familiarity, and to a certain extent, how that familial becomes filial when one is thinking of employing someone to take care of an older person. Secondly, it is through, it could be arranged by an intermediary who is not an ayah. So it could be a paid domestic worker or a cook, but who is not an ayah. Thirdly, it could be through an ayah who has, a family who knows a particular ayah and that family acts as referrals. And now coming to the second mode of entry, which is known as the indirect mode of entry within the ayah care service, which is where these centers and these placement agencies come in. Now, in case of working with these centers, ayahs have to shade out, they have to pay commissions to these uh, centers. And this also becomes the reason for which some of the ayahs would not prefer to work through these centers. Now, here I would like to pause and inform the audience that I began my fieldwork in the pre-COVID era. However, my fieldwork continued throughout the COVID-19 period. Now, this was a phase where many of these ayahs, they lost their job uh, due to the understanding that these ayahs, they could be, potential carriers of this pathogenic COVID-19 virus. And at the same time, when I wanted to approach the ayahs through the centers, they completely rejected the idea and they thought that I'm going to provide these ayahs jobs elsewhere. So this is also an important aspect that we need to keep in mind, the precarity of the labor and what placement agencies go through as well. Now, for ayahs, who do not wish to, enter this particular occupation through the ayah care centers or the placement agencies, there are certain disadvantages as well. The major disadvantage being that in case they are not satisfied with a particular employer, they will not have any choice to switch to another household. So that is something that came across in all the narratives in case of ayahs who were not, who did not enter the profession through the intermediary of these placement agencies. Now, these are again some of the terms that are quite recurrent and common within the ayah subculture. Diner ayah, which refers to an ayah who works for or works in the daytime. Rater ayah refers to an ayah who works during the night time. Running ayah refers to ayahs who are part-time ayahs who commute from their residence, from their own residence to that of the employer's residence every day. And also Shara Dineraya, which refers to a live-in full-time ayah. Now, again, during the COVID-19 pandemic, many of the running ayahs, they were given the offer of turning to a live-in ayah with the fear that since they are commuting every day, they are very much part of the public sphere. They are at greater risk of posing threat to these older bodies. And as we know that all the studies that were coming up during the COVID-19 period, especially keeping in mind the old age populace, uh, it tried to project that they are the at-risk population. So this is also where we need to understand. This is also a way of understanding, why many of these ayahs lost their job. Now, the methodology. So this particular study involves a combination of microethnography, which was conducted for almost 2 years in the home care setting of the employer's residence as well as that of the ayahs. As I have mentioned earlier, the initial process of going ahead with the research, going ahead with the study did not work out as the owners of the placement agencies, they were not quite okay with that idea. Now, 30 ayahs were interviewed, in-depth face-to-face interviews as well as telephonic interviews were conducted with some of these ayahs. The reason I went ahead with telephonic interviews, it has to do with two things. One, because many of these ayahs were interviewed during the pestilential COVID-19 period, A, and B, given their nature of work and the distance where they were living from my residence to their residence, they preferred that I'm not intervening their itinerary or intruding their itinerary otherwise. So that was also quite interesting for me. And I've also collected data via 16 family case studies that also enabled me to understand the dynamics of the co-present, co-residential family caregivers, and also their dynamics with the ayah, especially in case of this issue of who is the primary caregiver, given an outsider and ayah entering this interiorized space of the household. Now, moving on to the first section, as I would like to call it, the body as a locus of care. Now, the body of a care worker is a conduit through which care is performed, and the structural relations evolving out of dirty work are organized around the body. Contemporary home care relies on hierarchies in the allocation of care labor, the duality of affect and power asymmetry in dealing with leaky and open bodies as orifices become the site of care, and the gradual commodification of care. The transfer of intimate labor to an outsider or to the sphere of paid care disembeds intimacy from the family sphere and open pathways to the commodification and commercialization. The tactile element of care work rendered it ambivalence. Body undergoes disciplining, and at the same time, there is a self-governance aspect of body, especially in the presence of other bodies. This is articulated through prescriptions, and sanctions for the body that shape attitudes towards bodies through cultural caveats. In certain cultures, there are restrictions to touching people of the opposite sex, whereas in some cultures, bodily contact is permitted under certain circumstances. Across cultures, touching or bodily contact without consent is deemed as inappropriate and construed as harassment. This undergirds the themes of limits and liminalities invoked through the discussion of the cultural body. Now, apart from this, body, whether it is through the colonial, biomedical, or the capitalist market language discourse, is viewed as inferior, is objectified. It requires control and disciplining, and those visibly doing labor that demands contact with the body are stigmatized. In the medical profession, hierarchy is marked by distanciation from the body. This buttresses the division of labor between doctor and the nurses. Now, within nursing, we see that it is the junior nurses or ayahs who perform the most menial, undesirable, and residual tasks. This corroborates to what Julia Twigg has stated about the hierarchical configuration within nursing and distancing from body care work with vertical upward mobility in the form of promotion. The wide definition of body work spans the centrality of working on the physicality and materiality of the body, along with encountering and cleaning body waste. Now, within the Indian context, if we have to try to figure out what this outsourcing means, then we also have to locate it in the larger narrative or the larger discourse of caste. So this is where Meena Gopal makes a very interesting point, that outsourcing care work to an ayah, it stems from the ambivalence and disgust with the bodily substances that are sticky, slimy, and odorous. And it is an upper caste privilege to distance from the polluting tasks. Transferring this task to lower caste, lower class women mark the interlocking of caste, class, labor, hygiene, and gender. In fact, ayahs reported that they diffuse room freshener so that their employer's family do not feel uncomfortable and to ensure their convenience. Now, patients who are bedridden and incapacitated, their excretory activities take place in the bed or adjacent to the bed. Ayahs referred to this as নোংরা পরিষ্কার করা or ময়লা পরিষ্কার করা, which in English translates to as cleaning dirt. Now, hoisting patients to clean their dirt demands vigor and physical strength. The ayahs need to demonstrate their physical strength, hence, while lifting a patient. They refer to such patients as chagano or lifting patients and feel that as a person ages, their bodies become loose and unbounded, uncontrolled, and heavy. So, therefore, the risk of this unbounded body, characterized by bodily disintegration and emission of residual substances, evokes further repulsion for the ayahs. Now, in the next slide, I want to give you an overview of all the tasks performed by the ayahs that I am referring to as intimate body care labor related tasks. So as you can see, shaving beard, shaving underarms, chipping nails, bathing. So it could be full body bathing, shoulder bathing, drying the body, washing the body, brushing teeth, cleaning mouth, applying toothpaste on toothbrush, measurement of urine discharge, cleaning facial substance, installing urinary catheter and bedpan, applying powder, lotion or cream, combing hair, massage for pain relief and facilitation of blood circulation. Now, this is an excerpt. So, I'm citing an ayah about her experience of providing intimate care labor. And according to Maloti, and her description is also provided right on screen, that an older lady under her care could earlier self-manage her excretory activities. Later, she lost control on her bodily functions and would often get submerged in her own excreta. This caused difficulty for Malati, but she was quick to point out that for Dida, now Dida is a term and it's a kinship term, and I would again draw your attention that this kind of terminology is also one of the ways of negotiating this kind of repulsive, repugnant nature of labor that many ayahs have mentioned during the narratives, the situation. And now moving over to the next section, that is of abject labor. Now, why do we have this feeling of disgust, or what evokes disgust for us? Now, to contextualize this through Mary Douglas, links repulsion towards body waste with the overall discomfort with dirt. The notion of dirt has semblance with disorder or matter out of place. Hence, there is a kind of urgency to fix it and restore orderliness. Dirt represents anomaly that could potentially bridge social organization. The routine standards of hygiene have semblance with purity and pollution, which is also intrinsic to Hinduism. So there's this theorists like Curtis and Biran, they have recognized five elicitors of disgust: bodily expression, spoiled food, certain living organisms, the other categories of people, and breach of social norms. And out of this, bodily secretions is the primary cause of disgust, as have been found by these authors. And the sensory cues, the tactile feeling of sliminess and clammy and sight of disgusting objects, all this cause a feeling of disgust that stems from the distressed response. So this was about the dirt and disorder aspect. Now, coming over to Khenna, or this elicitors of dust that I have already pointed out, but fluid and open personhood. Now, this is where I have found Sarah Lamb's work quite important and interesting, where she talks about that how through this mutual touching or this corporeal encounters uh, during her field work, it is believed that the substances in a person is going to get transferred to to the other person. And this also makes sense in the context of when ayahs, after the completion of their duty, they prefer to take bath with a feeling that they are doing dirty work, but at the same time, they feel that the properties of the patient who are sick, who are about to die, who are in end of life care, or who are in different stages of dependency and care, it may get transferred to them. So that is also another interesting aspect that came across. Now, this further, explains the reservation of eating food cooked by a group or a person as potentially polluting. So here I am trying to take you through this entire idea of pollution and purity as believed within Hinduism, within discursive Hinduism. As it is believed, the one who is cooking, the qualities of that person permeate into the food. The cleanliness and hygiene norms, as evident in ayahs, through this compulsory bathing after completion of duty, it is also in a way to ward off or stave off the pollutants from the body. These transferable properties are known as dravya, as articulated by Maxim Marriott, and therefore, there is this underlying fear of substantial exchange that results in moral ambiguity and predicament in doing work. And this moral ambiguity and predicament is not just limited to the ayahs, but also their family members. So the ayahs, they believe that the kind of tasks they have to perform on a routinized everyday basis, it is kharab kaj. This is by kharab kaj we mean that this is something one cannot speak about much. Therefore, there needs a kind of censorship. And this also has to do with our idea of how we think that bodies in end of life care or dying bodies or dead bodies are sites of impurities. Now, India, inconsistent with many cultures across the world, uh, talking about death or being part of a labor force that encounters with death for livelihood amounts to taboo. And this has also come up in the work of Jonathan Parry when he was doing his field work in Banaras, where he found families of shopkeepers who were selling funeral materials. They adhered to a very low profile life as they had to live off death. This also explains the establishment of these cremation carts or these cremation sites outside the precincts of human settlements. Now, for ayahs, the idea of bad death or perverse death lies in suffering in the social world that permeates the body and intensifies pain. Bodies that are at the brink of disintegration, contravening its bounded state, and foul smell, incontinence, and difficulty in eating. Therefore, this entire labor is thought of as undignified and profane in nature. But there is also another aspect of this intimate care labor that only exacerbates or renders the stigma aspect. And that is of blurring the boundaries of intimacy while performing ayah care labor. And here the ayahs talk about inappropriate intimacies, like just to cite an ayah where she talks about while while cleaning the excretory regions of a male patient, how the patient would suddenly grab the ayah or grope the ayah. And while initially she feels uncomfortable, one of them at least reasoned that this could be due to the cooling of the body that one experiences due to old age, and therefore bodies are pining for human warmth and human intimacy, right? So that is one way of looking at it. Of course, this is a clear case of sexual abuse or the asymmetrical power relations in the sphere of the ayah care labor, and many of them are aware of it. But at the same time, they censor this information from their family members with the view that if they come to know about it, they will not be able to go ahead with their work the next day. And given the kind of precarious and abject poverty they are part of, losing a job will cost them more than they can imagine. Here, I would also like to point out that the husbands of these ayahs, that is the male members of these households, they are largely part of the seasonal labor cycles, as a result of which that they have intermittent jobs. So, unlike these ayahs, they do not have a regular kind of employment, even though that is in the informal labor market. So, this further exacerbates the position of the ayahs. To quote an ayah, Kamala, a live-in ayah who had a role transition from a paid domestic help, recounted her experience of attending to an older man with dementia who was highly dependent and was on urinary catheter. There was an instance when he would soil himself and the trail of the fecal matter left a foul smell. She referred to the patient as Baba, a term within our linguistic structure to refer to a father. And that parent-child dyad enabled her to overcome aversion. Although she was advised to stay away from contacting the fecal matter of an ill person as it contains germs, however, she felt that using gloves for hygiene is not required as he is a father figure. Now, this is also very interesting. And here I also find a kind of, I mean, at least just through her narrative, I find a contrast with that of Julia Twick's work, where not providing this hygiene supplies to the ayahs is deemed as how they are part of a part of an occupation where they cannot even assert these needs for themselves. However, in case of Komula, she felt that this kind of hygiene supplies may also act as barriers, because if it was her own biological father, she wouldn't have used hygiene supplies. So this is again a very interesting way of understanding proximity and ambivalence and the complexities of doing intimate labor. Now moving on to the next section, that is of how the ayahs, manage uh, their everyday life of doing this kind of labor, as we have already seen that this is not at all easy for them. So the first aspect is that of taming the visceral feeling of aversion. Now this takes a lot of time. Sometimes the ayahs never get a closure in actually disciplining themselves to an extent where they can tame their very innate natural emotions of disgust. Next is that of internalization of dirt. Now, this is very interesting because when I went ahead and asked the ayahs that don't they feel repulsed when they have to clean someone's bodily discharge, and the next moment, they have to have their own meal. One of the ayahs said that she has repulsion towards selective bodily matters. So she is okay with puke of a human being, but she is not okay with, say, the fecal matter for that matter. Interestingly, the ayahs also stated that they have to internalize in order to survive in the, I mean, they have to internalize dirt or the immediate or the visceral emotions that dirt evoke in order to survive in the occupation. Otherwise, they will not be able to make through or make their daily labor even manageable. And this also leads to a kind of desensitization. And here again, I would like to pause and talk about that how, when we are thinking of ayahs, especially because they are part of this informal labor market and they do not have any forum or any collective or any platform to air their voices, their grievances. This is an aspect where a kind of training, or I wouldn't say training, a kind of cohort group discussion would help in a certain way. Next is that of excluding or censoring details to avoid shame and stigma. Now, this is something I have already mentioned, but just to reiterate here, that ayahs, I mean, this is in a very different context when they're talking about not sharing information enough or elaborate information with their family members. So I would like to take you through, this particular anecdote where I got to interview this ayah in the employer's residence, and later the ayah felt, I mean, she was so much in the flow of conversation. She wanted to, continue talking with me. And so after her duty was over, we went to her residence in the urban slum. And she was very particular when she was talking with me. So whenever her husband would be there, the tone of the conversation would change. She would deliberately keep away or refrain from using certain phrases, or keep away certain information. And later she told me that uh, if the family members, they actually know the extent of dirt handled by the ayahs, handled by them, they will not feel comfortable having food from these women. So this is something I've already tried to establish, that the kind of labor one is part of, it is thought that the substances or the properties are also ingrained within the body of the person who is performing. So this is where just it just got reiterated through this particular ayah's anecdotal narrative. Uh, Another way, and another key way, which all ayahs I have seen across the spectrum, they have found, a legitimate way or a very go-to way of dealing with this repulsive nature of intimate body care work, that is of assuming the role of a parent. Now, this is very interesting because life course approach or childhood studies, or gerontological studies for that matter, have time and again showed that how there are certain convergences and continuities between childhood as a phase in the life course as well as old age in the phase of a life course. And a lot of this intransigent behavior, or when a patient is not actually conceding to the instructions of the ayahs, or the very nature of handling the dirty aspects of ayah care labor, is in a way carried out or negotiated through acting as a metaphoric parent in case of the ayahs, and treating or deeming these older people as metaphoric children. And since we think of children as someone without agency, someone who needs a little bit of more cues to go ahead with their everyday life, I just feel that, it enables them to go ahead with this routinized nature of intimate care labor. And finally, but not limited to, when advantage with favorable outcome. Now, this is something I'm going to again reiterate in the next section as well, that within the feminized informal care market, if we think of paid care, I mean, paid domestic service, paid cooking, paid culinary service, or paid cooking service, and ayah care service, it is ayah care service which relatively gives a little better wage. So when one is part of this kind of a labor where there are immediate disadvantages, where one has to deal with such kind of repugnance and precarity, this also becomes one of the drivers or a kind of motivating factor temporarily to go ahead with their everyday labor. Now, coming over to, I hope that I'm not running out of time. Yeah, yeah. Now, coming over to what makes this ayahs confined to ayah care labor to begin with, or in this particular kind of care work to begin with. Now, one is that of Keen like intimacy and labor as duty. Now, this is something I have already stated at the outset of the presentation, that when we think of the discourse of care or what constitutes care, especially in the Indian or the South Asian context, care is considered to be as a duty. Also, it's in a way a right of the older generation that they should receive from the younger generation. And that is why an aberration of which also brings in a kind of, reprimand for the younger generation. So ayahs feel that they get to experience this kin-like intimacy, and given the overlap with nursing profession or the labor of nursing, they think of taking care of older people or this particular nature of labor as a kind of duty, which is very interesting because the same ayahs who had prior experience or who has also attended to children, they do not associate their labor of taking care of children as a duty. So this is very interesting. So another term that is used within the ayah subculture is that of patiented duty, that is duty for the patient, which, yes, one may also say that it reinforces this particular image of older people as patients. And of course, we can have conversations on that later on. Then coming over to concentration in single household and decrease in hassle of commuting. Now, for a paid domestic worker or a paid cook, uh, the kind of wage that they will make from a single residence or a single household will not be enough, as a result of which they juggle and balance working in multiple households in a day. And they divide their time. So working in the day, so they may work in three residences or three households in a day at the daytime, and two or three households or more. So I'm just giving an example of it. Now, given Aya Carework has better prospect of earning compared to what one can make through paid culinary service or paid domestic service. Concentration in a single household is definitely an advantage that IAs are weighing, and at the same time, it also minimizes or reduces their hassle. So this should make us aware or draw our attention to the aspect of chronic fatigue or burnout that care workers go through. And this is also one of the reasons that why family caregivers, they are outsourcing care. It has not always to do with, or the popular literature, especially coming from this medical gerontological literature, which thinks or which deems that a particular birth cohort, they are abdicating and absolving their responsibility of not taking care of their parents or their larger kids. But it also has to do with the nature of labor or how care is intensive. And I was reading somewhere that how this care homicides or care murders are also becoming so common. So this should also be indicative of the intensive and laborious and strenuous nature of care itself. Then coming over to comparative dignity or elevated dignity. Before that, I would like to explain these two terms, tolakaj, which is colloquially referred to, used for paid domestic service, and ranna kaj. Ranna refers to cooking, which is referred to, culinary services. Now, this comparative dignity term is very important. Now, it's not just in my study, but I've also found in Claire's Stack's study when she interviewed this home care nursing aides who, despite the tent and the stigma that the occupation brings in, found that the home care nursing, the home care aides, they derived pride, esteem, and dignity through the kind of labor they were doing. So here, in this case, since some of these ayahs were also earlier working as paid domestic workers or they were in paid cooking service, they could actually make that comparison. The shift in dignity that they have started experiencing, not just from their family members, but also from through the from the employers itself. Because again, when you are trying to you know resuscitate someone, when you are trying to provide uh, a kind of support to someone who is in the stage of crisis, it definitely uh, can boost the model of not just the person who is receiving care, but also the person who is delivering care or planning out care. And this also brings me to the fourth point, which is related to the third point, that is well-being of older people and the transformational nature of healing labor. Now, this is something I have discussed extensively and fleshed out better in a paper of mine, where I'm also like proposing for, given this transformational nature of healing labor that ayahs have mastered in a certain way, it also calls for acknowledging and advocating for this knowledge from below that these ayahs bring to the table. Because care that is being provided, both for, I mean, care is an exchange, and the one who is providing care and the one who is receiving care, it can be transformational for both, because there are many other aspects associated with it. And like in one of the papers that I just mentioned about ayahs, they feel that they are not just, you know, administering medicine, or they are not just helping someone with assisted feeding, but they are also in a way reintegrating relationships within the family, reconciling relationships within the family, especially in case relationships have gone sour. And this is all the more important in case of end of life care, where I, as I felt that you know, one of the important ingredients of bereavement support has to do with tethered living, because human beings have linked lives. I mean, these are terms we as academicians we use on and off, but again, from the IAS perspective, the very idea of bad death or perverse death also has to do with when you are when you are facing risk, when your body is disintegrating, but you do not have any, you know, primary kinds or co-residential family members to take care of you. And finally, coming over to the aspect of better wage, vertical upward mobility, and shift in consumption patterns. Now, this is something one of the sociologists from India, Rajni Palriwala, also talks about. That how, given the intermittent employment patterns that the male members of this ayahs go through, women in a bid or with a view to, you know, make up for the rise in different kinds of materials, they need to make up for it. And given the change or shift in consumption patterns, this relatively better wage helps them in some way to, you know, feel that they're doing something aspirational. So again, we, when we think of class mobility or upward mobility, we always try to aspire the lifestyle or the, you know, the living pattern of the ones who are above us. So for the ayahs, you know, their ability to buy, say, makeup products, or their ability to send their children to school, or their ability to pay their own house rent, uh, not just provides them esteem, but also it makes them feel very good. Now coming over to, okay, there's some issue with, yeah. So now coming over to the final aspect, as I can say, of this particular presentation, where I'm trying to talk about, or rather, I'm trying to, you know, bring in all these pieces of the jigsaw puzzle together. And just to reiterate what feminization of care work looks like. So, the reason why we are talking about precarity of ayahs or precarity of doing intimate labor, it also has to do with how we synonymize the very idea of care with feminine temperament or feminine principles. And when we think of care, the first image that comes to our mind is that of certain qualities and certain kinds of dispositions that are considered as very natural to women. And therefore, when we find ayahs, when they are, you know, juggling, when they are switching from paid domestic service to paid culinary services, they continue to, although yes, they get relatively better wage, but they continue to face the financial marginalization that we have been talking about. So of course, there's not just feminization of care work, but there is also an aspect of feminization of poverty. I also want to draw your attention to the aspect of neoliberal economy. So this is something you know, has largely been talked about by Saskia Sassen when she's talking about this, you know, global chains or these global circuits of inequality and feminization of survival of the circuit. So something that I have already discussed, that when men in the household, they are not part of full-time employment patterns, it is the women, or it is through the women, that their household economy, their family economy is carried forward and continued. And that also positions these women, and by women I specifically mean the ayahs, to not actually be in a position to make those bargaining that otherwise would have been possible. I've also mentioned time and again through this presentation about the degrading nature of labor and its relation to caste. So, the caste history in India, as we all know, or for the ones who are not aware about, so menial tasks have always been concentrated within the laboring castes of the lower castes. And the upper castes, who have also been understood as this non-laboring bodies, they always had the privilege not to be part of certain kinds of occupations. And that is also one of the reasons we see that this ayahs face different kinds of tauntings from their own employers. And I particularly remember this incident, and which I would like to talk about here, that how one of the male employers told his live-in ayah, that live-in full-time ayah, that the kind of work you do is so degrading, it's so denigrating, and so you do not have any right to, even assert yourself. So this also again reiterates that how the employers also perceive these ayahs. But having said that, I would also like to talk about the resistance the many of these male employers especially show towards the ayahs, also has to do with how now, since they have to, abide by the instructions of the ayahs, it becomes a kind of an onslaught on their caste, gendered, and class privileges, because they are not used to, being told around or being, instructed around by, women, women of lower caste, women of lower class, which in case of paid domestic service or paid cooking service, one may not have to directly indulge in. Care work, dignity, and profanity. So again, coming back from what I have already stated, uh, even in such circumstances, even within this very profane and polluting nature of work, finding dignity can become very tough. But again, the way we think of healing humans, the way we think of resuscitating humans who are especially in stages of crisis, and just to, make a point over here, how an Aya stated that yes, despite the tensions, the power asymmetries that she faces, she knows that the patient is in a way bodily marginal. So there is a kind of bodily marginality that the patient faces, which she is not experiencing at the moment. So that also makes it very interesting when, as they are negotiating with the kind of labor they are part of. And then I've used this particular concept by James Scott, hidden transcripts, that IAs also have their own ways of showing micro resistances. And again, this is not to invisibilize or take away, or in a way to, elide that the kind of job they are part of, it is very denigrating. But having said that, they there are ways, when an aya, when a patient is not listening to the aya may choose to, completely go away from that situation. And there are very small ways, and there are other examples as well, where they assert their, agency, even if it is momentarily, but they do so. uh, and finally, I advocate for that how one needs to find a balance between the universal and the local cultural, modalities. Think while we are, trying to conceptualize and think of care labor. And I also make a distinction between care as labor and care as practice. So, although I have titled this as the concluding part, but this is more of, certain afterthoughts and future direction that I have for this particular paper or this presentation. One is that of care as service and care labor as fatigue. Uh, right. So, on one hand, I'm so sorry. So, on one hand, the very foundation of care is deemed as a kind of service, and that also open up these pathways for discussion on the kind of wages the ayah should receive, or the kind of wages one should receive if one is providing any form of care, and that also includes family caregivers as well. But having said that, care as labor draws attention to the aspect of fatigue that we usually do not talk about, and especially in case of family caregivers, talking about fatigue, talking about exhaustion, talking about the saturation point that one reaches on providing certain kinds of care, especially in case of end of life care, not so much in case of convalescent care, can really take a toll. I also talk about, or I rather, want to have this discussion regarding the multisensory aspect of care work. Uh, when we think of care, we have a tendency to think, especially at least it may have come across through this study, that we are only interested in the tactile nature of care. But care is, say, multisensorial. Some ayahs, they become so familiar with the smell of a patient's body, or the way a patient is looking at things in life. So all these aspects, if we integrate into our understanding, can really push for a very complex, but at the same time, a very rigorous way of adding to the home care model. Then intimate work and possibility of contested intimacy. The very idea of contested intimacy that I have spoken about, it also emerges from the fact that this blurring boundaries, or this sharpening boundaries that otherwise exist for domestic workers or this paid cooks, may not apply or may not exist for the care workers, because the kind of labor they are associated with, it involves touching the body, and as a result of which it makes body care work much more ambivalent, much more ambiguous, and it can also pose certain kinds of risks to the ayahs, but also to the patients, because all this while we have been only trying to understand the issues that may be confronting the ayahs, but what about the patients? Uh, as we have said, that the power asymmetries can be turned upside down as well. So ayahs may also be in that position where they can inflict some kind of bodily pain or violence on the patient. Then tensions in sharing or retaining dirty work. Now, this is again very interesting, because all this while we have been made to think that dirty work or this polluting nature of body care labor is something that is outsourced. But there are, at least through the family case studies, I have found that some family members, they deliberately retain this so-called polluting nature of care labor to themselves, with a view that this solidifies the bond. So I will give you a particular example of this couple where the older woman, she was completely bedridden, she was highly dependent, and she was diagnosed with Parkinson's disease and early stage dementia. And the husband, although had employed an ayah, but preferred to you know clean her excretory regions and did not allow ayahs to do that ever. So this is again, should gives us, I do not know whether it's a new direction, but at least for me, I have found this quite intriguing, that what retaining certain kinds of body care labor may mean to different caregivers. And finally, curing versus caring. uh, when we think of care, the other side to that is cure, because cure has always been part of this expert, scientific, proto-professional regimes, versus care, which has always been, in a way, at least within our imaginary landscape, been part of something that does not require training, does not require capacity building, does not require any special assets, and as a result of which it has only gone on to sharpen this dichotomy between care and cure. And we also find ayahs facing that, where a lot of some family members, not a lot of family members, they stated that if they had more money, they would have rather uh, hired a nurse rather than an ayah, because in the initial phase of their induction, the family members felt that the ayah, some of the ayahs who were very much new to the job, they were not quite proficient and lacked that kind of rigor that they felt that a nurse would have brought to the table. So these are some of the aspects with which I would like to end my presentation. I do not know that whether I have exceeded time. I think I have exceeded time, but I'm so sorry about it.